Heart rhythms. Let's see some basics. P wave, it's an atrial rhythm. QRS wave, it's a ventricular rhythm. Lack of QRS complex is an asystole, and wide Bezier QRS complex VTAC. Any chaotic or unorganized rhythm will be a fibrillation, and if there is no P wave, then it will be an atrial fibrillation. If you see a Bezier rhythm, it will be a tachycardia, and if it is with a wide QRS complex, then it is ventricular tachycardia. A sawtooth rhythm will be atrial flutter. So you can see this terminology is in exam, and you can mark the options accordingly. Let's see what is sinus tachycardia. As its name says, it's a sinus rhythm with greater than 100 per minute in an adult. Note that P waves are still present. The rhythm will be normal. There is a P, Q, R, S and T deflections and intervals. This sinus tachycardia can be caused by varieties of factors such as pain, fever, dehydration, fear, anger, anxiety, caffeine use, due to some medications and other underlying conditions. First degree heart block. First degree heart block is a sinus rhythm with prolonged PR interval that is greater than 0.2 second, which is caused by delay in electrical conduction from SA node in the atria to the AV node in the ventricle. So this can happen due to some reason, which includes medications, heart disease, or any damage in the heart. Mobitz type 1 second degree heart block is characterized by progressive lengthening of PR interval until a QRS complex is dropped. You can see in the rhythm, PR intervals get longer with each complex until conduction is completely lost. Thus, electrical signal that normally stimulates the ventricle, the heart to contract does not fire and the heartbeat is skipped. Long, long, longer and a drop. So this is second degree heart block, Mobitz 1. Again a second degree heart block. This is Mobitz type 2. It is characterized by intermittent dropped QRS that is not in Mobitz 1. So there is a intermittent dropped QRS here, and the interventions are symptomatic second degree heart block interventions, drop in blood pressure, dizziness, fainting, confusion, syncope, shortness of breath, signs of decreased cardiac output. So what we have to do? Inform the rapid response team, prepare for transcutaneous pacing, give atropine if bradycardia is present. Third degree heart block. Third degree heart block, sometimes it is called complete heart block, is a rhythm where there is no relationship between P and this QRS waves. You can see here it's P and the QRS is here. There is no relation. This is very dangerous. It is associated with bradycardia and cannot sustain an adequate perfusion. Interventions. There will be a drop in blood pressure, dizziness, fainting, confusion, syncope, shortness of breath, signs of decreased cardiac output. So what we have to do? Inform the rapid response team, prepare for transcutaneous pacing, give atropine. Of course, there will be a bradycardia. Supraventricular tachycardia. In this rhythm, there is extremely fast atrial rhythm with narrow QRS complex. The QRS complex, you can see it is very narrow. It's not life-threatening. The treatment is Valsalva maneuver, that is increasing intrathoracic pressure and affecting baroreceptors within aorta. Ask patient to hold breath and exhale forcefully as if straining during bowel movement, holding nose and exhaling against the obstruction. Hold the breath for a few seconds and then cough. The medicine which is given is for SVT is adenosine. Atrial fibrillation. It's very common atrial arrhythmia. In this rhythm, you cannot see an identifiable P wave. There is a fibrillation. You cannot see a P wave, which cannot be identifiable. And intervals between each QRS is irregular. QRS interval is irregular. Electrical impulse from SA node is not conducting properly, and the results are a short circuit-like response. Atrial flutter. It's a supraventricular arrhythmia that is characterized by a sawtooth flutter appearance on ECG that represent multiple P waves for each QRS complex. So after each QRS complex, you can see multiple P waves. The key identifying factor is that there are multiple P waves in between QRS complex. These patients will be scheduled for a procedure called ablation. That means a part of heart that is causing this flutter will be swapped so that the part responsible for this irregular rhythm are killed, and so that the SA node can take over, and again it can start with the regular contraction and there will be a regular heart rate. Assistole, which depicts a flat line. Assess the patient, check for pulse and breathing. If no pulse or breathing, call a cord. If the patient is a full cord, begin delivering high quality CPR. Attach the patient to AED in the event that convert to a shockable rhythm. Follow the protocol to resuscitate the patient. Ventricular tachycardia, VTAC or VT, is an ECG rhythm that is characterized by bizarre widening QRS complex. There is no P wave and usually the rate is over 100 per minute. VTAC may quickly convert to ventricular fibrillation and even death. Immediately assess the patient. If alert and able to follow instruction, have the patient cough forcefully, bear down like they are trying to have a bowel movement. This vagal response may be enough to break the tachycardia and return to the sinus rhythm. And if it doesn't work, you must immediately notify the provider. Ventricular fibrillation. It's a shockable rhythm, which means it may be responsive to electrical defibrillation. This is an emergency. Assess the patient to determine if there is a pulse or not. If this is a true rhythm, patient will not have a pulse. So if you see like this and if it is true, this patient will not have a pulse. So adequate treatment should be given. So can you identify this rhythm? This is a normal sinus rhythm, bradycardia, ventricular fibrillation, ventricular tachycardia. As we discussed, there is a widened QRS, atrial fibrillation, atrial flutter with sawtooth and more P waves, supraventricular tachycardia with narrow QRS, torsade points and an assistole. Thank you.